Thank you, Dr. Rowe. Good morning, the audience. This is my great honor to here share my medical research. I enjoyed yesterday's workshop. The translational research is the main focus that encouraged me to change my speech to more bigger scale than previous topic that I provide. So today I want to talk about, it's also my dream, the translational research for malignant brain tumor. First of all, I would like to thank NHI to continue providing me the research funding and direction for more than 13 years. In 2001, when I come back from UCSF, although everybody told me it is very hard to get an NHI grant, I still encourage myself to apply a proposal. Of course, I'm very reasonable. It was rejected. But I did receive many great suggestions and comments from the committees. Just like a lighthouse that leading me the right direction for my research work. Without this guide, I could not go on till now. 30 years later, since then, I have been supported by NHI grant, and this year I got another 5-year grant, and also I got a chance to stand here to share my experience with you. It's my great honor and also great pleasure to me. And last week, I was invited by the head of UCSF Brain Tumor Center, Professor Richberger, who is my boss in UCSF. He arranged me to give a talk about a similar topic as today at the annual UCSF Neurosurgery Update course. I'm just like a student facing the midterm test, and I thought I could never be well prepared. I'm very cautious and prepared for more than 2 weeks for these 2 talks. I wish I can well express my study in today's talk. So can I spend a few minutes to introduce the brain tumor, about the epidemiology and also the clinical treatment. The brain tumor, about 80,000 patients, years diagnosis with spinal brain tumor in the US, and more than 50% are glioma and glioblastoma. This tumor is very high malignant and very also a very terrible fact is no risk factor. The peak age about 50 to 60 years old patient. And the average median survival also very poor. It's only 1.2 years. And the symptoms including the headache, seizure, neurologic dysfunction like the hemiplasia, gait disturbance, visual loss, personality change. It's like a shock. It's very big impact for health people. The tumor like the autopsy, this one, there's no tumor margin. And the priority treatment of the tumor is surgery to get the tissue proof, and then radiotherapy and chemotherapy as the adjuvant therapy. But even this aggressive management, in 2005, a very big lecture resection, the patient survival also within 1.2 years. But in this big patient, some subgroup have these features. If surgery can grossly total remove the tumor compared with partial remove, the patient's survival were different. So this is the in-front treatment of the brain tumor. The majority is surgery. Without surgery, patient cannot survive more than half years. So the surgery is a primary, but surgery we must face many challenges because if you want to aggressive resection, we are afraid of the normal brain tumor will be damaged because the tumor is ill-defined. And then the radiotherapy, including the photon beam therapy or proton beam therapy or radiosurgery, this is the true radiation therapy agent. And then because of the chemotherapy and the target therapy, patient from 1 year to 1.2 years. Why only 0.2 months? Because the blood-brain barrier block this kind of the drug and this kind of the target therapy. Even in clinical practice, we can put some guerrilla waffle into the brain region that will break through the blood-brain barrier. So this method also get some improvement. So my mission is how to balance between the increased lifespan and also keep the quality of life for the patient. And so I propose a research plan, and this is also the agenda of today's talk. First, I will share with you how I to collect the clinical data, including the diagnosis, therapeutic response, and also the sample, including the cell line, blood, etc. And also use this clinical sample and take the high technology of the system biology, like the sequencing, deep sequencing, or the other technology, and then get some target and functional study for the potential target for the treatment. Maybe we can find another target therapy. And then also study the microenvironment of the brain tumor. And maybe I put most effort in the therapeutic development. The first one, for the surgeon, the most important is how to improve the surgical outcome. And then how to improve the drug therapy. This is how to break the blood-brain barrier to let the chemotherapy drug into the brain. And also another drug delivery technology, convention enhanced delivery. Maybe today I have no time to describe. So from 2001, after I died from the UCSF, I copied the sample collection methodology from my clinical work. Because the brain tumor, the tumor core, margin, and peripheral, there has many different microenvironments. When we took out the tumor, we can get roughly this 3 region sample. And also some patients got a recurrent tumor, and we must do the second operation or the third operation. This different timeline also provide treatment response, tumor evolution information. So this tumor evolution and treatment response. And also, I also collect some primary cell culture for the validation of the result of the analysis, and also for the clinical trial purpose. I also set up some PDX model, and the most important, the treatment response during the follow-up. For example, we must to monitor the tumor response via the MRI. In the same time, I also collect the blood sample. The blood sample can equal to the MRI image. It also can provide some treatment response. From this big data I have from 2001 until now, I already collect more than 1,000 patient samples. And about 5 years ago, I collaborated with Dr. Li Hu at Institute for System Biology in Seattle. We have two proposals. One proposal is take the peripheral part and the tumor core. We have 8 patients, all belong to the GBM patient. We analyze these 2 samples using many different technologies to analyze the information of this sample. And also the second project, yes, I collect 2 times reoperation patient from the first time, and then the first recurrence, first operation, and second recurrence, second operation. I have 3 samples and also have the blood sample. So every patient has 4 specimens, and I collect 10 patients and use the whole genome sequencing to take a look about the tumor evolution. But initially, I want to take this information, integrate to the clinical to find out some treatment target. But because the manpower and because the data is too big, and also one professional person from ISB to Chang'an Memorial Hospital, until now we also cannot analyze this kind of the formation. But I just an example about we cannot get a lot of important information, but we pick up one very important clinical gene is IGF, and this IGF in the deep sequencing data, we can see the tumor compared with the normal, and also recurrent tumor compared with primary tumor, the level always high. So I collect another 140 patients to stain this sample, and also use siRNA to knock down the IGF-BB3. We can see the tumor activity is low after I knock down the IGF-BB3. And also in this 140 patient, we can see the similar expression of the IGF-BB3, and also compare with the clinical outcome. Then also IGF-BB3 high level is poor prognosis. And also use this U87, the human cell line, we knock down the IGF-BB3 and implant into the new mice. Also see the tumor volume also decrease. And I also spend some analysis and also got some upgrade radiation or downgrade radiation compared with the IGF-BP3. And this target we will analyze this, if reasonable, can talk a very complete story. Maybe we can put this annual study to a new mice. So I spent the time in the biology study, and also I spent the therapeutic development. And the first one, my dream is to set up an advanced surgical theater in my OR. In 2012, a journal of clinical oncology that emphasized the intraoperative stimulation mapping to be a standard of care for glioma surgery. Previously, we operate the tumor, just took out the tumor and took out the enhanced region, and if the enhanced region to near the more elegant area, then we will let the tumor stay hid there. But this kind of operation cannot prolong the patient's survival. So glioma resection with intraoperative stimulation mapping are associated with 60% reduce the severe neurologic deficit. So if we can use the intraoperative stimulation, then maybe we can get the gross total resection of the tumor and then got the better outcome of the tumor management. So this is our setup. I call this is anatomic localization, because the MRI have some functional MRI. We can perform the functional MRI in each patient, because the patient functional location is individual. So different patient is different pattern. So we can pre-operate it to set up the functional MRI, and also got some tractography and also some diffuse tractography to analyze the sensory and motor region and integrate this information to the OR and use the navigation to get a very correct anatomic localization. But for the brain tumor surgery, the most important, except for the total resection of the tumor, save the patient's function, also very important. According to this year's Journal of Neurosurgery, Dr. Mitch Berger and Eddie John, they collect the patient from UCSF, more than 1,000 patients. They can observe the speech cortex in different patients is variable, very variable. And also, Dr. Dufal, he also a neurosurgeon. He is expert awake surgery in Europe, and he also published many journals about the brain plasticity. For example, initially, the first time operation, because this region is speech arrest, is also the speech area, broca or vertical area, and so did not remove this part. But second time, when the tumor recurs in this area and he repeat the mapping, it shows this speech rest region disappear. So he can took out the tumor in the second operation. So based on this knowledge, so we set up I'm so-called the advanced surgical theater in my OR. This equipment including the anatomic localization of the intraocular MRI navigation and also functional localization. I use the major method is awake craniotomy. Also, I took some electron monitor to give some help. So this is our guideline to management glioma patient is modified from the UCSF Brain Tumor Center. And I show some sample, some example. I integrate 6 camera view in one monitor. This shows the patient close-up view and surgeon view, and also some electron monitor and the rehab doctor to test the motor response or sensory response. It's quite a very busy operation. And this is anesthesiology, and this part is surgery. And some assistant over there, they collect this sample into this monitor. And this one is the patient view and some questionnaire. And this is the navigator. And we also collect this 3-channel panel into a smart goggle. So the operator can see the different information from when he switch the point in the goggle. He can see many kind of information during perform operation. And this goggle got the first place award of the smart wear device competition. And other than the operation, and maybe this is I put most of the majority time I put is develop a brain drug delivery system. As you know, I just mentioned a little about the brain tumor, about the brain tumor character, because the core, the enhancement tumor part is the red line, and the green line is the infiltration tumor region. In surgical part, we only can remove the red part because the green area is the normal brain. Although there have some tumor cell infiltrate at there. So we only remove this part and left the other part in the brain. So the tumor recurrence always from the peripheral margin. And this green part, their blood-brain barrier also intact, because this area, not like the tumor core, already destruction some new vessel development. So the adjuvant therapy of the chemotherapy cannot reach this region. So if we can break out this door, then maybe we can put some chemotherapy, some gene therapy, some target therapy to this region. Maybe we can control the tumor growing. So we took the methodology of the focus ultrasound to open the BBB. Later I will explain the mechanism of how focus on to open the blood-brain barrier. Right now, the methodology to open the BBB in a clinical setting is the hypertonic solution, like the mannitol, but this non-specific and also not so effective, so we don't use this one. And the most standard is the glial waffle, but glial waffle is need to perform the operation and put the glial waffle in the tumor bed. So this is no blood-brain barrier issue. And this one, so-called convection enhanced delivery, right now already reached to the phase 3 clinical trial in the US. Push a needle into the target region and infusion with power, some infusion with power and delivery some drug into this region according to the design. And then the fourth one is focus ultrasound to open the barrier. The mechanism of the focus ultrasound to open BBB is use focus ultrasound interact with pre-administered microbubble to the target area and vibrate generated by microbubble burst may result temporary deformity of the capillary endothelial cell of BBB open. And this BBB open will transiently and then after some time, capillary endothelium will expand afterward and then close the blood-brain barrier. We can use the gadolinium under MRI imaging. We can see the open BBB is equal to the gadolinium leak, and then maybe about 6 hours later, the gadolinium will not leak, and also the blood-brain barrier is closed. We can observe the BBB open, use the electron microscope. As we take picture in 2010, we can see this nanoparticle combine some drug within the open gap of the endothelial region. I borrow some video from the YouTube. This is provide the Inside Tech company.
Our method consists of using an ultrasound transducer and focus it at a specific region on the order of 3 millimeters. After administration of microbubbles, which are micron-sized air-filled lipid shell or protein shell bubbles, together with injection of the drug of choice that would treat the actual brain. So you have the drug that circulates at the same time as the bubbles into the bloodstream. Those bubbles are set in vibration at the same frequency as the ultrasound beam and are exerting mechanical forces on the barrier. The capillaries are also set to vibrate and as a result exert mechanical forces on the tight junction. The barrier will actually start loosening up and let pharmacological agents that are also in the bloodstream to go through the area that's affected.
I just talked about the mechanism, and then I will show how we translate the other character or technology into this system. The focus ultrasound is different from the diagnostic ultrasound. Diagnostic ultrasound, their target is very big, very large, and the focus on the target only very tiny. And this is traditional diagnostic ultrasound implant. And focus ultrasound, there are maybe two. One is bowl shape, and the other is a sphere shape. And the focus on red is safe because its energy is lower than diagnostic ultrasound, and even lower 10,000-fold compared with thermal ablation. This thermal ablation right now is going on in the clinical for the Parkinsonian patient. And how to prove the BBB open? We use two methods. One is even proof. Even proof is related a mobile molecule. So we can see after we treat this region and the even proof link. And also we can use the continuous monitor with the MRI. And after treatment, we infusion the gadolinium and can see the target region the gadolinium enhance will present, and then we will. This is meaning the blood very open, and also we use the even blue and the gadolinium to test the opening time of the BBB open. And right now the design of the ultrasound, the probe design, three systems. One is from France group. They implant the ultrasound into the skull and then direct to treat the tumor underneath. And our group is the bullshit. Bullshit is will move very easy. And the inside tech group is the semi-sphere and patient fixed and don't need move the ultrasound probe. And because we treat the target in not only a tiny point, it's a three-dimensional target. So we use the 256 channel array to move the channel array, but the probe one target don't need to move, and the array will switch in different area and then can construct a three-dimensional target. And another issue is about the bomb. Bomb will decrease the energy of the ultrasound, of the focus ultrasound. We also test in different human skull sample, and also to detect the percentage of the energy decrease and to adjust after we want to treat and we want to set up a very effective opening energy. But we did not treat the mouse because the mouse we just one direction we can target all the tumor, but we treat the patient. The patient, the head is very big. So how to guiding the ultrasound tip to the tumor region is a problem. The inside tab, they use the MRI guiding. So the patient must go into the MRI room to perform the laboratory open. But our system is different. We take advantage of the surgical instrument. This navigation system is our daily use. The navigation system can guide our instrument black into the tumor region. So we also use the navigation system to guide our ultrasound tip to the treatment region. So we integrate the neuronavigator and the probe. We can very precise to treat some certain target. And we test the accuracy of the navigation guide. In swine model, we can reach to 2.3 millimeter. is acceptable for the clinical use. So this is the whole system, briefly introduction. This is the prototype of the ultrasound probe. And this is the navigation system, and it will guide the ultrasound into the tumor region. Just the patient must be fixed in the chair. And so we also perform some drug delivery. Initially, at first, we just want to prove a concept. So in 2001, we proposed a very, very complex nanoparticle, magnetic guiding, and also MRI imaging to show the drug get into the target and concentration, and also tumor volume and survival. But the result is that we can get very promising result. We can decrease the tumor volume, and we can prolong the tumor survival under the assist of ultrasound guiding the nanoparticle drug into the brain to treat the brain tumor. But if we want to get into the clinical, we cannot get so complex system. So we feedback and we draw back. We will use a very traditional, very old drug. It's BCNU. Just use the BCNU under ultrasound assist to increase the local concentration and show the decreased tumor growth and prolong the survival. But the BCNU is not used in practical, so we use another, the first line drug is temozolomide. Right now we use in the clinical, in the rat model. We can see this even blue region can show the concentration increase and survival also prolonged. But in clinical, if we want to get preclinical data, the rat model is not a very good idea. Mouse is maybe better. So we use the human cell line implant in the new mice to observe the response of the temozolomide treatment after ultrasound assist. We also got a similar result. And then, because right now the clinical use, other than temozolomide, another target therapy is Avastin. Is an agent is for the anti-angiogenesis, and we also use the focus on assist Avastin delivery to the tumor. We can also more big benefit for the tumor control. And also in the slide we can see CD31, the angiogenesis is decreased after the ultrasound assist Avastin delivery. So in summary, we use this system to test many different kinds of the drug, and also got a relative good concentration increase and the survival benefit. So based on this system, in 2013, the IEE Spectrum magazine also introduced our system to say rays of ultrasound could get lead drug into the brain. And also another magazine, Fortune, say 5-way ultrasound, focused ultrasound is changing the medicine. The one for the drug delivery, they say is from our system. And also this result also get some promote in Taiwan. So in conclusion, I will compare with right now in the market, maybe not yet. It's all preclinical study. But the first one is from the French group. Is cathedral. They implant fixed ultrasound in the skull and test the safety of the ultrasound. They already complete this study. They get the data if the safety is no problem, but not to see the treatment result, because this is maybe not very reasonable, because tumor will grow in, tumor will change, so fixed ultrasound cannot help very much. And maybe the most big company is Incytek. Incytek, they already go in the phase 1 trial. They use the MRI guided focus ultrasound to open the blood-brain barrier. But this system, every time when the patient receives the MRI guided focus ultrasound, the patient must get into the MRI room to get this kind of assist for the drug delivery. This is maybe not ideal, because the patient receive the chemotherapy or the target therapy, then not only once, instead of many, even maybe 2 times a week. But our system, we use the very mobile navigation, then we can perform this procedure in the ward or in the OPD. And because compared with this result, we think maybe we can go into market. So we propose a preclinical GLP study. For the medical device, every data must get the GLP data, and GLP data is not performed in our lab. It's performed in the regular standard lab. We see the safety for the red safety of ultrasound in the dog, and also the safety of ultrasound plus hematoma in the rat. And safety for the ultrasound plus drug in the dog. We all got the safety is no problem. So we propose clinical test. We will propose during regular chemotherapy. We perform 2 times ultrasound assist to enhance the drug get into the brain tumor region. And also because this system is combined medical device and drug, so it's very difficult to get improved in TFDA. So after 2 years TFDA consultation, then we went to FDA to get some idea about this system, how to design this system. We hope the idea and the comment from the FDA can help us to get the TFDA approved for the clinical. So the goal is we want to use the design to prolong the patient life under the ultrasound assist new drug development to control the tumor, and also under the operation technique improved, we can improve the quality of life of the patient. And this job is involve a lot of people. For the sequencing, it collaborated with the liquid. And for the animal model from the NIH Terry. And the clinical operation technology from the UC Richburger and France, Dr. Dufal. And also in Taiwan, we also get many professionals to help to improve, to complete this proposal. But this was only, I think maybe only half. It's not finished.